Good day, everyone. My name is Danny Weiss, and I'm a neonatologist at Sunnybrook in Toronto. Along with Dr. Danielle Rios, we are the co-chairs of the Neonatal Hemodynamics Research Center Education Committee. We're proud to present the latest webinar in the TNE Foundation's curriculum. Our speaker today is Dr. Regan Giesinger, who is a clinical associate professor at the University of Iowa. She's presenting today on a fantastic topic on cardiovascular associations among patients with HIE and how to optimize cardiovascular care, a topic that she's in the forefront in both research and in clinical application of these key and foundational principles. So very excited to hear her speak today. I want to welcome our panelists who are trainees in neonatal hemodynamics and targeted neonatal echocardiography. They are joining us as usual as panelists. I would invite them to keep their camera on during the seminar today. And a warm welcome as well to our other attendees who are not visible but warmly welcomed as well. And reminder for everyone to kindly put any questions they have along the way into the Q&A box. There will be potentially some interactive questions along the way with panelists, and there'll be a chance for both panelists and other attendees to address any residual questions through the Q&A at the conclusion of Dr. Giesinger's talk today, and I'll be moderating that session. So without further ado, there's one final announcement to make. That's just our acknowledgement that the Neonatal Hemodynamics and TNE-NP Foundation's curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals. Okay, Dr. Giesinger, thank you very much.
Thank you for the introduction. I will just put up my slides here. All right, thank you again very much for inviting me to speak. I have hopefully put together a talk that is both interesting and practical. And for anybody who has done teaching with me before, you guys know that I am totally open to be interrupted to ask questions. So I want to make sure you guys understand what we're going through here. So please feel free to get my attention if there's something that you don't get before we move on. So the basic objectives of this talk are to really understand how fetal protective mechanisms and other considerations of transition impact on the clinical phenotype of babies who present with neonatal encephalopathy caused by hypoxia ischemia, to talk about the role of RV in this disease, and to also talk about some important therapeutic considerations and some mimics that can catch you out if you're not aware of potential.
Ask everyone to please mute their mics. Thank you.
Thank you.
So I'm just going to continue on by kind of giving you a little bit of a big picture view of why some of this is important. There has been sort of dabbling of studies in the relationship between cerebral blood flow and brain injury over the past 20 or so years, although really the literature has started to pick up over the last 3 to 5 years in greater detail. We know from old studies that cerebral blood flow is higher with lower resistive index in babies who have more severe brain injury. There's a suggestion that cardiac output is distributed more towards the central nervous system by the end of the cooling period among babies who have abnormal brain MRI. And pulmonary hypertension and RV dysfunction both have been associated with more abnormal MRI in the neonatal period, a greater risk of neonatal death, and also a greater risk of adverse neurodevelopmental outcome and in toddlerhood. And so the question remains is whether these findings are associations, as in the primary injury was such that both the brain and the heart were injured at that time, and therefore they're co-travelers? Or are these potential contributors to ongoing brain injury, and therefore are they modifiable?
Okay, bye.
So this is important because there is a lot of complexity in this disease process. So the insult, hypothermia itself, and rewarming all have a lot of implications on the cardiovascular system, both in the areas of vascular resistance, tone, loading conditions, and also heart function and oxygen handling and distribution. And so there's a lot of potential areas where neonates are vulnerable to ongoing ischemic or reperfusion injury in the process. And when we just look at from a clinical perspective, the way that this manifests in our own practices is that babies with this issue are also at risk of failed transition and acute pulmonary hypertension. They often have impaired heart function, and probably this estimate of transient myocardial ischemia in 1/3 of infants is a dramatic underestimation of the actual magnitude of the burden of cardiac dysfunction in this patient population, because all of these older modalities of evaluating this were relying on really poorly sensitive and specific diagnostic tests. So when we drill down to more sophisticated measures, this is likely a much larger burden of the problem than we know. And we're going to focus mostly on these two areas in the following talk, but also it's important to think about the fact that other organs can be impacted, and most relevantly to us are the adrenal gland and the lung, and thinking about pneumothorax is always important. So to start off, from a kind of basics of physiology perspective, this is a complicated diagram, but basically what to take away from it is that the fetus in utero does a very good job of trying to protect itself from the impact of abnormal placental delivery of substrate. And already the PaO2 is fairly low, but ischemic conditions bring out a very predictable response in the fetus that has certain implications as the baby transitions. So step one is that we've all heard of the diving reflex, right? So the diving reflex results in centralization of blood flow to brain, heart, and adrenals. And this occurs because there's a catecholamine surge that vasoconstricts everywhere else and brings the blood to those central locations. And that has relevance because patients who are under normal in utero conditions do still circulate some blood to their lung. And as they're preparing to, as fetuses are preparing to deliver in that kind of contraction phase, et cetera, a lot of changes in hormonal stimulation actually occur in order to prime the circulation of the pulmonary vascular bed to have blood go there in the upcoming future as it gets introduced to air. And so the vasoconstriction in the lungs removes that priming process and decreases pulmonary blood flow from the normal 10% to something lower. And this increase in pulmonary vascular resistance helps because it shunts more blood across the PFO and encourages more cardiac output to the important areas just by raising right ventricular afterload. Do you guys have questions about that before I move on? No, okay. So then when the baby is born, thinking about the fetal circulation, we have placental flow traversing the atrial septum about 50% of volume. And then another 90% traverses the PFO to go, or sorry, the PDA to go towards the systemic circulation and back to the placenta. When the cord is clamped, within the first 4 heartbeats, there's a 30% increase in SVR, a 50% decrease venous return to the left atrium, and ongoing right to left ductal shunt for a while until ventilation is established. The problem with this is that obviously, if the left atrial filling is not replaced very rapidly by pulmonary blood flow, cardiac output can be very severely compromised, and you end up in a hypoperfusion state at that point in time. And I bring this up in the context of HIE in particular, because newborns taking their first gasp are much more effective at clearing fetal lung fluid than we are at delivering those positive pressure breaths. It's just by the nature of physics, their effort is much more effective. And so a lot of what we're doing with positive pressure is trying to stimulate them to breathe, stimulate those airway reflexes to breathe. And babies who have HIE oftentimes don't take that first breath. And so we need to do a good job of helping to support them. So then what happens? So basically what happens in all babies with pulmonary hypertension is you build a brick wall across the pulmonary artery. It's an uphill battle to get blood to go there. Therefore, there's a brick wall across the pulmonary veins, and there's not enough blood filling the circulation to the left heart, and you end up with compromised cardiac output. And common causes of this in babies with HIE are simultaneous lung disease, which we know is highly associated, and also just asphyxia on its own, acidosis, hypothermia, and as I mentioned, impaired clearance of fetal lung water. And this is all on the background of the setting of being primed to have high PVR because of fetal adaptive mechanisms. So from this physiology, we'll go to just a little bit about how we assess these patients, just a couple of slides. And one of the things I want you guys to take home from this is that it's actually very difficult in a lot of situations to really know, based on looking at the baby itself, whether this baby who appears to have impaired perfusion, does that apparent impaired perfusion relate to an ongoing problem or the problem that they started with? And a lot of that has to do with the fact that we really don't have good definitions for anything. So this is a study that we conducted a couple of years ago. We asked a lot of different NICUs across North America what definition of low blood pressure they were using for this patient population. And as you can see from my very brightly colored pie charts, the answer is a lot of different definitions. And so on the background of this type of clinical practice, it's really hard to know how we're all doing the same thing. Yes or no, we're probably not. And therefore, it's really hard to study, and it's really hard to manage in an evidence-based way. The other thing that's relevant is that the lactate and metabolic acidosis are also quite difficult to interpret. So on the right of this is the relationship between the base deficit and lactate with the severity of the original insult. And you can see that that ROC is pretty good to predict the degree of presentation of encephalopathy. On the right, you can see that there is a graph, a scatter plot, basically showing the rate of decline of lactate as related to cardiac output measured by NICOM in the first 6 hours. And this particular study, although small, basically shows that there's no relationship to either one of those things. The other important thing to know is that HIE and also therapeutic hypothermia on its own, purely just temperature, modulates many of our other metrics of adequate organ flow, for example, renal function. So many babies with HIE have acute kidney injury, which may actually be quite severe. And apart from that, just lowering body temperature alone has an association with reducing urine output. And this is a very interesting study, the bottom left there, where they took adults with normal renal function who had not had any reason to have low urine output and reduced their temperature gradually to 33 degrees. And what they found was that for every degree reduction in temperature, they had 5 mils per hour less urine output. So when your baby with HIE isn't peeing, there's a lot of plausible reasons why that might be the case. So here is an example of a case that illustrates a little bit of some of what I'm talking about and sets up the next couple of slides. So this is a standard baby that you would see in any tertiary practice. So this is an infant who was born essentially at term, at a normal birth weight. There was cord prolapse and an emergency C-section was done. Cord arterial gases were poor. APGARs were poor until 15 minutes. And the baby presents to you with a heart rate in the 150s, is kind of breathing spontaneously, kind of ineffectively. Some of it is a little bit of gasping. The blood pressure has a mean of 45, 49/35. The baby has been cooled up to this point, and is on pretty reasonable ventilator settings, only small mils per kilo of tidal volume, the PEEP7 in room air, on a bit of Butamine, a bit of hydrocortisone, with still residual significant metabolic acidosis and a lactate, which has come down, but which is still elevated. So looking at this baby, does anybody want to comment on what they think is the likely finding, or some of the likely findings that you might see on echo? And or do we think that this baby might have, what are this baby's odds of having a normal echo? I have two of my local fellows here, so if nobody else says anything, oh, and a local resident, or three of my local fellows here. So if nobody says anything, I'm going to ask one of them and then move on to the rest of you. So first of all, votes for normal. Put up your hands for that. Some shaking heads. Okay, votes for mild or moderate heart dysfunction. Just chat here. Okay, so some votes for poor heart dysfunction. A vote for poor LV function in the chat. What about severe heart dysfunction? Maybe, maybe, not quite sure. Okay, so I will show you. So you guys are mostly familiar with reading echo, so you guys know that this is an apical four-chamber picture. What stands out?
Dilated RA and RV.
Yep, dilated RA and RV. And if you had to put money on, TAPSE, and my options for you are 7 or more, or less than 6.
Less than 6.
Yeah, less than 6. Okay, agree. So this is a little kiddo who had severely dilated RA-RV and severe RV dysfunction. So I'm going to just show you the baby's chest X-ray, and then we're going to talk about how this could be the case, that this baby with such severe heart dysfunction, and presumably pulmonary hypertension based on the etiology of this in this patient population, is it potentially still in room air. So here's this kid's X-ray. Looks pretty good. And there's one term that expresses intact ability to have these two things congruent. Does anybody know what that is? And then I'll explain it. One term that expresses it. If no, that's okay. Aki Hassan says pulmonary hypertension. Yes, the baby does have pulmonary hypertension. I can tell you that, but he's in room air.
Regan, what was your question?
So my question is, what is the term for what is intact in a baby who has pulmonary hypertension and a bad RV, but is in room air?
To do with the coupling between the RV and the PA, that it's still intact at this point, so it's coping.
Yeah, so partly right. coupling of the, but it's not quite coupling of the PA to the RV. It's actually coupling of the ventilation with the perfusion. And so basically what babies with HIE do, because they can have completely normal chest x-rays, they can actually adapt for a long way to highly vasoconstricted lungs through a process called pneumoconstriction. So I'll just take you through this quickly. So on the left, you have the normal state, well-filled alveoli, well-filled vessels. You have an adaptive state here in B, where there's meconium or something in this airway. And as a result of that, the smart blood vessel that comes near it vasoconstricts. And so you have an adaptive low flow. Here's another adaptation, which is what babies with HIE typically do. So you have this normal area, but over here you have an area which is vasoconstricted because of two things. One, because of the intrinsic pulmonary hypertension that we talked about, but secondly, because the RV is delivering so little blood to the circulation that the vessels actually vasoconstrict in order to compensate for that tiny amount of blood, so that they can actually bring blood, the tiny bit that they get, to any aerated areas. So in order to do that, the alveolus itself, or a part of that apparatus, actually blocks off air from going to that area, and you get pneumoconstriction, so that the blood can be, so that the air can focus on the area with the blood. So these are the babies who are in room air with bad RV function and a normal chest x-ray. And this obviously is a problem when you have no flow and also no limited aeration. And these babies present in the typical way with acute severe hypoxic respiratory failure. Does that make sense to you guys? Yeah, good. If not, okay. So hard to understand sometimes, but pretty easy once you break it down. So the other thing that's really important about the interaction between the lung and the vessels is that, and I'm sure a lot of you guys have seen this before, but it's really important in this disease because there's those babies with normal chest x-rays and no lung disease. It's really easy to mess this up. So your lung volume helps to determine your pulmonary vascular resistance. If you're way too low, that's the typical thing that you get in the whited out lung pulmonary hypertension preterm who hasn't transitioned because they have so much lung disease that they need a lot of pressure to open up, and then eventually they'll transition if you do that. And then on the other end of the spectrum, you have babies where you put so much pressure into the alveoli or airway unit that it actually smushes the blood vessels beside it. And because babies with HIE, again, oftentimes have no lung disease, you really have to be careful that you're not on this top end of the curve. And this is an example of a baby where this was a baby who came to us here who was transferred from a referral facility for a pre-ECMO assessment. And at the referral facility, they were on the sensor medic oscillator because we don't have the VN500 oscillator in the US yet, dropped. This baby was on a MAP of 20, was on a power of 5, which equates to something like an amplitude of 50, and a frequency of 8, and had preductal sats in the 70s with postductal sats lower than that. We did an X-ray to confirm ET position right after the baby came, and the baby was actually transferred on the high frequency oscillator anyways. So we just matched the settings that they were on before, checked the positions of all the lines and tubes, allowed the transferring team to depart, and then basically did a compliance assessment. So we took this baby off, handbagged, moved the chest, and eventually settled back on SIMV with pressures of 23/5, a rate of 40, and a mean airway pressure almost half at 11. And just with that, the baby's SATs came up to 100 and the FiO2 was able to be weaned. If you look at these chest x-rays, they look pretty much exactly the same. And so while it is important to get chest x-rays, use chest x-rays, and in many ways you have nothing else for these types of things, a healthy index of suspicion for a baby who's got pretty black looking lungs is important in this population. And if you especially if you don't know how you got to where you are, there is, and as in you're coming into the baby, not having watched them escalate, and people are very tempted to go up on mean airway pressure to try and fix FiO2, but that presumes that the flow portion of your efforts are normal, and therefore you can end up in a place you didn't intend. So handbagging or having an experienced RT handbag can be a really invaluable tool. The other thing that's really important is that temperature is a really important modulator of not only urine output, but also pulmonary vascular resistance. This is another real case. We got asked to see this baby because prior to cooling, because she had a really severe metabolic acidosis and was in 40% oxygen with a clear chest x-ray. So there was some concern potentially about pulmonary hypertension. And because we scan all babies with HIE here, it was like just kind of part of our normal assessment. You can see that the clinical status is the usual kind of story. At the outset, so at the time of our first echo, these are ductal cuts, which I think you guys hopefully will recognize. But the first assessment was at a temperature of 35 degrees. The PDA here was mostly almost all left to right, with just a tiny titch of bidirectional, the same sort of a thing you see when the baby's pressures are equisystemic, with that little bit of early systolic right to left. The blood pressure was 50s on mid-30s, and the baby was in 40% oxygen, as I mentioned. And then as we cooled, we actually stood in the room and measured, presuming we were going to need to repeat the echo afterwards. And we actually watched as the baby's temperature went down, the FiO2 went up, such that by the time she got to 33.1 degrees, she was in 100% oxygen with SATs in the 80s. And you can see that the blood pressures are similar, and you can see that the ductus has almost entirely switched direction. And this is the reason why cooling is a post-resuscitation intervention, and should always, one of the reasons, not the only reason, but one of them, should always be done in a place where consideration for escalation of therapy is possible. And if you think about the implications of this, we already talked a little bit about the fact that our previous case had an awful RV, and I'll talk a little bit more about why the RV in a second. But in a situation where you have a high pretest probability of pulmonary hypertension and you have a high pretest probability of heart dysfunction, it's important to know what your therapies are likely to do when you implement them. So you guys have probably seen this graph before, but it's an important one. So I'm just going to put it up again. This is the stress velocity relationship. So end systolic wall stressor afterload and rate corrected VCF, which is a marker of contractility. And then the adult here with their flat curve, and the neonate with the very steep curve. So with a small increase in afterload, you get a pretty decent decline in function. So this is important because you already have pre-existing potential problems. And in the end, if the ventricle can't generate enough force to make the cavity pressure in the RV higher than the pulmonary artery pressure, blood is just not going to go, and you're going to just exacerbate your RV dilation, maladaptation, dysfunction, low cardiac output problems. And so this is the vicious cycle of acute pulmonary hypertension. Basically, The baby gradually gets worse and worse. As the cardiac output goes down, the coronary perfusion pressure goes down, and RV experiences more and more ischemia. And this is how babies with HIE acutely die in the neonatal period, as in if they can't be stabilized, this is the usual reason why. So why the right ventricle? So the right ventricle is particularly relevant for a couple of reasons. One, because pulmonary hypertension is a particular problem. But secondly, even if pulmonary hypertension was not there, the RV would be at risk of injury because it has a much higher metabolism and a more prominent role in transitional circulation. And this is because of metabolism, but also it's because of shape. So the RV wraps around the LV. It's more thin-walled. It's disadvantaged by not being able to form a circle or a cone, and therefore the wall stress that is placed on each individual myocyte is actually higher than a more, you can call it ergonomically shaped left ventricle. And the other thing is that the coronary flow, as I just previously mentioned, is more vulnerable. And just before we move on, understanding the coronaries is, in this disease is important because it's a really fundamental issue of management. So this is particularly relevant because the flow in the coronary arteries goes from the aortic root on the systemic side of the circulation to the pulmonary side of the circulation, and is determined by the difference in pressure between the aortic root and either the coronary sinus or the RV cavity pressure, depending on the area of the coronary that you're talking about. These babies, oftentimes, because of pulmonary hypertension, because of vasoconstriction in the lung, oftentimes have very high RV and RA resting pressures, both at systole and at diastole. And when you combine that with low cardiac output, therefore lower aortic root pressure, it's difficult to maintain that gradient of flow to the right ventricle. That makes sense to people? Some nods, good. Okay. So here is a typical presentation of a typical baby. Term infant, emergency section, the baby had a poor tracing, the APGARs are abysmal, the baby had extensive resuscitation at an outside facility about 40-ish minutes away. The baby arrives to our unit at 5 hours of age, was already cooled, and had been started by the referral team on dopamine for low blood pressure and was ventilated. The baby had quite a boggy head and an asymmetric CFM. So our local clinician was concerned about intracranial hemorrhage, and this baby was already cold. So they wanted to do an emergent echo prior to sending the baby for head CT. This was the baby's x-ray, somewhat concerning. So now knowing what we know up to this point and what we've learned from the previous baby, right ventricular function is what we should expect to be abnormal. And indeed, this is this baby's apical four-chamber. So this baby was cooled, so is more bradycardic. And you can see by these numbers, knowing that normal TAPSE at this age should be around 9. Normal fractional area change obviously should be more than 25 in the 4-chamber and 35 in the 3-chamber. And the RVS prime is low as well, but not as low as the other 2 measurements. So what we suggested, what do you guys think that we should, what do you guys think as a principle? Should this baby go to CT right now? No, I see some shaking heads. No, baby should not go to CT right now. Baby leaves the unit, baby is likely to arrest in the CT scanner. Especially as was on dopamine, right? So we're already doing some things that I'll talk about in a minute are a little bit sketchy. So instead what we recommended was don't let this baby go These are the other measurements that we have. You can see that the ejection fraction was a little bit abnormal too, but that was much more likely to be ventricular shared fibers as opposed to primary LV disease, given the severity of the RV disease. And so our goal is to stabilize this baby first, and make sure that they're not going to cause the fellow who has to go with them to CT to call a code. So some therapeutic considerations for this type of patient population. They do have high pulmonary artery pressure. So we oftentimes think about treatment with nitric oxide for babies who have low or high pulmonary artery pressure. But there is no data in this population. Nobody studied it, but also kind of not supremely logical to use a selective pulmonary vasodilator because they usually have intact VQ matching. A couple of people in the chat have mentioned changing the cardiovascular agents. Completely agree. One of the things that really needs to be done here is to support the right ventricle. And drugs that do that are Dobutamine, primarily are Dobutamine or Epinephrine. Those are two good choices. And what you might use is clinician dependent and acute illness severity dependent, but one of those is important to add to the cocktail. And then we often think about prostaglandin as a pop-off, and this ductus wasn't so small, but that's something to consider also. If you give the right ventricle someplace easier for things to go, just like in any treatment of acute pulmonary hypertension, you can make the RV function better. And I agree with the plan to stop the dopamine, but it's important not to stop the dopamine cold turkey, because if we go back to our coronary perfusion pressure, if you just stop the dopamine and don't replace it with something else, oftentimes you're going to drop your coronary perfusion pressure too much, and then you end up with exacerbating your problem again. So things that we typically use would be vasopressin or norepinephrine in those types of situations. And I have a big red disclaimer there, which will come up on my next slide. Do you guys have questions about the management question up to this point, or does this all kind of seem logical to you in the context of these babies? Good.
No, but I think it was the CT was. Oh.
So Pearl is trying to tell you that our recommendations were not necessarily followed in this situation. and
Sorry, I didn't know that I was not muted.
That's okay. So in actual fact, our prediction came true. And was it you, Pearl, who had to go to CT?
Yes, I was the one that had to go to CT with the baby, and the baby coded in CT.
Yeah, there you go. So you guys all would have done it better and nothing would have happened in CT. All right. So what the things that we're going to want to avoid are dopamine, especially at high dose. All high dose catecholamines in general, although norepinephrine is probably the best one of the bunch, and milrinone. And we're going to talk about why each of those in a sec. So this is a study in asphyxiated piglets where they gave either 20 mics of dopamine or 10 mics of dopamine plus epinephrine at a pretty generous dose to asphyxiated piglets without any other consideration. They were normoxic. And this showed that in both groups, the pulmonary artery pressure went up significantly, and the ratio went up by about 194 to 100%. And so dopamine has been shown in other populations to be a pulmonary vasoconstrictor, and that includes pulmonary hypertension without HIE, preterm infants, etc. So generally speaking, dopamine is not recommended for pure PH HIE unless there is no alternatives. No need to apologize, Pearl. Epinephrine, this is a really high dose, but epinephrine at a lower, more inotropic dose is probably okay because the increase in PAP and SAP are sort of proportional to each other and are dose dependent. So if you keep it low, you're probably all right. This is a small cohort of patients who had refractory pulmonary hypertension, as in they were all on, to qualify, all on at least 60% oxygen despite nitric oxide with stable optimized ventilation. And there's 3 groups here. The green group got just therapeutic hypothermia, so they were HIE patients who were cooled. The purple group got no cooling. They were regular pulmonary hypertension and got treated with milrinone. And the red group got treated with both. And what you can see, and we've lived through this enough times anecdotally to be skeptical of babies in this situation. What you can see is that there's pretty dramatic drop in blood pressure, both systolic and diastolic, shortly after administering the milrinone. And that's accompanied, more importantly, by a really dramatic increase in cardiovascular vasoactive score. So if you think about way back to the beginning where we were talking about not wanting to cause ischemia reperfusion injury, this is probably something that we would prefer to avoid if possible. This is preliminary data, probably more study is needed, but it's at least something to be suspicious of. So now I'm going to move on to a couple of different types of considerations for the last few minutes of the talk. And these are things that are not always unique to HIE, but relatively common in this patient population. So we talked about PGE as a pop-off, the way that we normally use it in pulmonary hypertension. But here is a baby where you have a giant sick right ventricle and a ductus which is all left to right. Does anybody want to take a crack at why this might happen?
Is this baby on INO?
Nope. This baby is in 30% oxygen.
Is it because the RV the function is really poor, and so the pressure is not generating enough pressure to drive the shunt to be right to left? Very
good. So this is an example of an uncoupled circulation. So, and the reason that this is more likely in HIE is because they also have primary ischemia. So this is a situation where the right ventricle is much more dysfunctional than its pulmonary vascular or its pulmonary artery pressure requires. It's pumping very poorly. And so the left ventricle, which is working better, is actually supplying the pulmonary circulation. And this baby will always be in low oxygen because they've got good, as long as they don't have concurrent lung disease, they've got good VQ matching, and they have pulmonary blood flow that's coming back from their left heart, but it's just circulating round and round and round in the left-sided circulation. So this is also sometimes an indication for PGE until you get your right ventricle better. All right, so this is just a graphic of that same thing. Does anybody want to ask anything about that before we move on? Good, okay. So here's another important thing to think about. This is Amy Stanford in the bottom left here. She was a trainee here last year, and this was at the very end of her training. So it was that scary situation where she was on call as a neonatal perinatal medicine fellow with this very sick baby, knowing that she wanted to echo, but not quite knowing if she had the right to do so. So she messaged me about this kiddo and said that this baby's in room air, no vent settings, clear chest x-ray, She's worried about the RV, totally appropriate, because this kid had a heart rate of 200 and a lactate of 18 and was a significantly asphyxiated patient who required a lot of resuscitation. But nobody was really interested in starting anything because the blood pressure was normal. And pursuant to our typical case we just talked about, she'd already ordered Butamine and Epi to the bedside. So I said, of course, Amy, you can scan this baby. And we both got a bit of a surprise. This is what she found. So this actually was a case of a kid who had hypertrophic obstructive cardiomyopathy, infant of diabetic mother that had been undiagnosed, who had significant mid-cavity flow acceleration of the LV and a very thick septum, and had just been given 3 code dose epi for resuscitation. So from what we know about hypertrophic cardiomyopathy, they contract really well, they just don't relax very well. And so code dose epi, while it's important in the moment because you need to get the baby back to life, has kind of some lasting consequences in this situation. And so just to review, the primary problem, these guys are ARNI. They have such big muscle that they can't put their muscle down. And so they get impaired diastolic performance, but ARNI can lift whatever he wants. There's no problem with ejecting. As a result of that, we have no problem with contractility. And so we can actually think about using both traditional methods of filling the ventricle, like volume boluses and minimizing mean airway pressure as possible, and nitric oxide if needed, but also a sort of an atypical way to fill the ventricle, which is filling the ventricle from the systemic circulation. And I put this slide up just to remind everyone that wall stress is actually proportional to pressure times by radius divided by the wall thickness. So when the wall is really, really thick, as these babies are, the wall stress is distributed over much more myocyte. And so in contrast to the RV, where the thin wall gets a lot of wall stress, these thick walls get a lot less wall stress. So you don't need to worry about raising their afterload. It's never going to be a problem. And this is how it works. So basically what you do is, by increasing your afterload, think back to the fact that blood goes from high pressure places to low pressure places. If the pressure in your aortic root goes up, the cavity of the LV reaches the same pressure equilibrium sooner. And so there's a little bit of blood that gets left behind in the ventricle because you have slightly lower stroke volume, which is no problem because this ventricle loves to dump things out. And therefore you increase your end systolic volume, and that adds to your end diastolic volume when it fills. And so you get this graph on the right where with every beat of the heart fills a little bit more. And so your approach to managing these babies, even though asphyxia is usually a Butamine epi situation, in this case, Butamine and epi, exactly the wrong thing to do. In this case, what you want is filling and vasopressin, because you're basically trying to make sure the heart is full and not help it contract. This is you guys can, I can send these slides or whatever, you can get this algorithm. It's published in manuscript, but basically what we show is a couple of different strategies. One is the strategy I just described, and the other is if the LV is severely obstructed, think about this as a hypoplastic right heart. We just talked about using the left ventricle to fill the pulmonary circulation. This is using the right ventricle to fill the systemic circulation. And importantly, these babies actually like to be cooled because it slows their heart rate down. And so they can actually sometimes be very stable through the cooling period, and it can give you an opportunity to fix some of these things, and they might actually manifest again on rewarming. So something definitely to keep in mind. And the reason that this ties in particularly to HIE is because it's not always a perinatal event. on its own that causes HIE. Sometimes babies who have perinatal events that might be mild, that have postnatal events where they just don't adapt very well. And so we have to keep in mind underlying cardiac problems when we're dealing with these patients, particularly when they're infants of diabetic mother. Questions about that? Good? Good, good, good. Okay. My last little vignette here. So this is a baby who, another one who came to us here from a referral institution who looked pretty much the same as the last one I showed you. 40-weeker, 4 hours old, no concern about the brain, so not going to have cardiac arrest in the CT scanner this time. But APGARs were low and did have extensive resuscitation, pretty similar in terms of their vitals. Heart rate 115, very appropriate for a cooled baby, reasonable blood pressure on low ventilation settings in room air, with still a capillary metabolic acidosis and a lactate of 9. And this baby basically got an echo because here we screen all babies with HIE, regardless of how symptomatic they are. So this is what we found. What do you guys think of that apex? First of all, which ventricle is worse, right or left, just by eyeball? And by, I guess you can see the number.
The left.
The left, yeah. So just by eyeball, you can see that the left is worse. It's barely moving. And in fact, if you cover up, if you use your hand to cover up this half, you'll see that the LV free wall is actually really not moving at all. And we got those numbers there for objective measurements, and we did have a little bit of mild RV dysfunction. But because we know that the RV is the more vulnerable one, we had a healthy suspicion about this baby, that this baby is doing something that seems weird. And so having a specific eye to things like congenital heart disease and other reasons for this baby to be like this, we kept going with the rest of our comprehensive assessment as usual and found that in this long axis view, you can see this little flop thing going there. We did other images of it also and called cardiology emergently, because this actually is a occlusive left coronary artery origin thrombus. And you can see from the cath picture, just to orientate you guys if you don't look at cath very often, this is the ascending aorta branches, descending aorta kind of posterior. It's taken at an oblique view. This is the coronary circulation to the right side. And this is where the coronary circulation to the left side is supposed to be. So actually there was basically no residual flow in the left coronary artery of this patient. And so in this case, we went back to the history and collected some more information about the perinatal course. And actually there was a lot less concern prenatally than we normally get about these babies. Oops, go back. So you can see that there aren't any cord gases here. That's because the cord gas is actually more normal. And this baby got all of this extensive resuscitation, probably because they had this thrombus in utero, and then their LV failed so badly to adapt to postnatal circulation that they had postnatal basically arrest. So in this case, eventually this baby got a thrombectomy and ended up on long-term therapy for heart dysfunction, but just raises the suspicion that if there's something that doesn't seem to fit the usual pattern, you have to go looking for other things in these babies. So some take-home points, and then I will let you guys ask questions, and we can see if there's any questions from the rest of the audience. One important thing is to really understand transitional and fetal physiology helps you understand why your baby is going to do what they're going to do, particularly in this disease. And if you can anticipate what the mechanism is of these babies kind of crashing and burning and eventually arresting, you can make a plan at how to stop it. They need support for their heart, and they need coronary perfusion pressure. And so the things to think about early on are, for kind of a crashing baby, are the cocktail of epi, PGE, and if low blood pressure, vasopressin. The other thing to remember is that there are mimics. So babies with congenital heart disease can be asphyxiated also. And so in that case, the combination of prostaglandin and epinephrine is a nice one also. So in the really, really sick baby, something to think about. We also need to remember that we absolutely can make these babies worse, even though we're trying to make them better. And so when you're doing something and the baby is becoming sicker, that is not always the baby. Sometimes that is you. And you should take a step back, reappraise the physiology, and say to yourself, do I have the wrong physiology? Am I using the wrong medication? Has something changed? Did the thing I gave make the baby worse? In which case you have to take a new tact and be humble. And you also have to watch out for babies who have normal blood pressure, because they can be pretty sneaky. And I have when one of my cohorts, I have a manuscript that's been submitted, which shows that you can actually have moderate, if not severe, RV dysfunction with normal blood pressure at 24 hours, even though you've given drugs to normalize the blood pressure. Under the seat, under the door, under the trap door, you can still have pretty bad disease. So low threshold, don't trust them. They're naughty. And that's it for me.
Thank you. Thank you, Regan. A really fantastic talk. I think illustrates why your work and is helping to help us care for these babies in a more holistic fashion. There's a pretty active Q&A, so I'll get to it shortly. I have a couple of questions, which I'll take the liberty of asking first. Just for the last case that you submitted, I was a little bit surprised that the baby was in room air. That pulmonary venous pressure is going to be quite high. So I want to ask you about what was the shunt direction at the atrial and ductal level. I'm expecting some type of left to right shunt at the atrial level, given the high LA pressure. Could you comment on that?
It was bidirectional at the ductus, but the ductus was pretty small, and left to right at the atrium. He didn't stay in room air for a long time. He kind of gradually developed pulmonary edema, but we caught him early on in his course, because he was admitted to us at 4 hours and then had his scan fairly shortly after. And so we were able to institute therapies and augment his mean airway pressure and get him down to the cath lab. But yeah, it's incredible what can be compensated for until it just is not anymore. That baby in most centers would have gone on for another couple of hours and then arrested probably, and nobody would have known why.
Okay, I do want to remind all of our attendees and panelists, and now please put all of your questions in the Q&A so that we can kind of categorically go through them all. So I'll start with a question from Eamon. This question is, what about epinephrine use in a baby with HIE who has a very high lactate? Would you still recommend it versus the Butamine? I guess in a baby who has myocardial dysfunction.
Yeah, so I think that you're always looking at risks and benefits. So if a baby has a very high lactate, and it is associated with, on your echo, severe or moderate to severe heart dysfunction with very low cardiac output, then the potential benefits of epinephrine, which are getting a greater inotropic benefit without as much chronotropy, so you get more inotropy at a lower heart rate, which is desirable in these patients, can be weighed against the potential risk of epinephrine mediated, independent of cardiovascular health, increase in lactate. And we know that some babies do that, some babies don't. The main disadvantage of that elevation of lactate is that it has potential to trick people into thinking that the baby is not getting better when they are. If you have a sick heart and the ability to monitor for it, then I would say the risks of epinephrine at a low dose the benefits of epinephrine at a low rate outweigh the risks of lactate that is going to just confuse the clinical team. If, on the other hand, you have a baby who has mild or mild to moderate dysfunction and isn't very sick, who has an elevated lactate where Butamine will probably do the job and the lactate is going to confuse people into doing things that may not be necessary, then Butamine is probably a better choice. So I would make the decision on the basis of the acute illness severity and what the consequences would be and how good your monitoring is.
Great, thank you. Gabriel had a question about, I think, the last case with the LV with the coronary left-sided coronary thrombus. Were there any ECG or ST segment changes or any prenatal arrhythmias?
There was a lot of change on EKG, and the cardiologists have actually written up a whole case report about that baby and some of those issues. We didn't have any history of fetal arrhythmia, and this mom basically had kind of presented unexpectedly delivering at the outside facility. So we didn't have a lot of prenatal history, but in going back to the story, there wasn't.
Great, thanks. There are a couple of questions on the baby who had was the IDM baby who had the obstructed outflow tracts. When do you consider use of a beta blocker in a case of a severe obstructive LVOT?
Yeah, good question. So we don't use beta blockers acutely for a couple of reasons. One is that many of these babies also have concurrent pulmonary hypertension, and the effect of beta blockade in the pulmonary vascular bed presents a worry of kind of increasing their PVR and then further creating compromise to left heart filling. Once you get them out of that transitional period and their PVR has had a chance to decline, then you can afford that increase in PVR, so it doesn't bother the baby as much and they don't tend to decompensate with it. So basically our acute approach is stabilization of blood pressure and optimizing filling. And then if we can't get that baby off of vasopressin in a couple of days, because oftentimes what you end up doing is once you get them started, they get full enough to get past a critical emptying point, then they keep themselves full and they're kind of okay and you can wean off your therapies. But if not, we use beta blockers as a transition to get them off of vasopressin and get rid of all the sodium problems that come along with vasopressin.
Great, thanks. A follow-up question was, could you guide us as to how you, I guess on echo, make the diagnosis of LVOT obstruction? What flow acceleration are you measuring?
So we're measuring it gradient through basically the aortic outflow tract. We follow it serially. And we use we don't use like an official definition of the way that a cardiologist would when they're looking at aortic stenosis or something like that, because it's a very dynamic process. But anytime there is a gradient of 2.5 meters per second across the outflow tract, that would be significantly concerning. And we would try to fix it, but if we can't fix it, move on relatively quickly. But in any situation where there is mid-cavity flow acceleration, that's kind of a baby on the edge of starting to get obstruction. And so we would kind of act upon those accordingly. That baby was about 2.2 meters per second.
Thank you. A question on hydrocortisone. Should we consider using early hydrocortisone for babies with HIE who are being cooled?
So I think it depends a bit on your perspective and why you're thinking about it. We know that babies are at risk of adrenal insufficiency. So certainly if you have a baby who doesn't respond to the first vasopressor that you give them, first of all, oftentimes they don't need vasopressors because they are cold. So they'll be vasoconstricted. If they do need a vasopressor, wonder why. Is that such bad cardiac output, or is that sepsis on top? Is that adrenal insufficiency on top? If they don't respond to their first line vasopressor, I would always presume adrenal insufficiency and start them on hydrocortisone. So that's sort of symptomatic management. Another way that you can use hydrocortisone as symptomatic management is in babies who have HIE, pulmonary hypertension, and meconium aspiration. That's a very inflammatory lung disease. And so hydrocortisone can be useful in that situation. And in that situation, I would think about using it early also. If you're talking about hydrocortisone as an alternative or as an adjunct to vasoactive medications, we have very little data. There's one randomized trial looking at dopamine alone or dopamine plus hydrocortisone, which showed that hydrocortisone reduced your requirement for dopamine. But since dopamine is something that we probably have much less of a role for in the first place, I'm not sure that that's necessarily not necessarily an endpoint in and of itself. But there was more hypertension also in the dopamine group. So you can make an argument that you might be able to minimize the amount of catecholamine that you need to give if you also give hydrocortisone. There's just not a huge body of literature aside from that one study to support it.
That's great. Thank you very much. A couple additional very thoughtful questions here. One, for the babies with hypertrophic cardiomyopathy and LVOT dynamic obstruction, when might you consider phenylephrine, I guess, instead of vasopressin?
Yeah, so that is a very thoughtful question. Phenylephrine is better than anything with beta-1 activity, but still there are alpha receptors in the heart. And so there is some impact on contractility there. So the main advantage to vasopressin and why it stands out amongst all the other pure vasopressors or relatively pure vasopressors is that it has, if anything, a negative inotropic effect. And what you want these babies to do is contract less hard. So if that's the medication that you're comfortable with and that's the only thing you have, by all means, it's better than dopamine. But having something that has no positive inotropy is desirable if you have the comfort level to use it.
Great. There is a question of, would you consider diuretics in a case of a severely dilated and failing LV?
Yep, you can. I didn't go through the full management here of severe LV dysfunction. It would normally for me be epinephrine plus minus milrinone if there's no HIE, and plus minus prostaglandin plus minus diuretics. I think all those things are reasonable. The caveat in HIE babies, if you're cooling them, your diuretics might not do anything. Because they're not peeing, and sometimes they still won't pee even if you give them Lasix. But I don't see that there's any disadvantage to doing that if that's felt to be clinically indicated.
Great. Question of the HIE and a trabeculated left ventricle. Is that something that you've encountered before?
So you mean
intrinsic cardiomyopathy? Maybe I think that's the question. Babies with LV dysfunction would actually relate it to intrinsic cardiomyopathy rather than changes in loading conditions or ischemia.
Yep. So the range of things, a short list of the range of things, certainly LV non-compaction and primary LV cardiomyopathy are important things to consider. We've seen that in babies with genetic diseases and developmental diseases in the past. And have had a couple of babies that we've actually cooled for that, even though they didn't necessarily have the encephalopathy criteria, but just to minimize metabolic demand. The viral endocarditis kind of milieu, particularly enterovirus. We've seen presenting in the early postnatal period where mom had a gastrointestinal illness and then baby presented with severe LV dysfunction, and ischemia are the kind of main ones that you see, and that can be either anomalous coronaries, although those don't usually present so early, or thrombi, or placental clots that we just don't see anymore that have now cleared, that kind of thing.
Great. I forgot to mention to our panelists, please, panelists are welcome to raise their hand and ask their question in person. So in the waning minutes, please feel free to do so. The couple other Q&A questions in the absence of our panelists having questions. One of them is again from Eamon on the use of milrinone. I guess it's asking, would you never use milrinone in HIE babies? And is there any association with worse neurological outcome? So any indication in HIE babies, and what's the long-term impact?
Yeah, so the short answer is HIE plus cooling in our practice means no milrinone until they're outside of that early transitional period, and until we've documented that their renal function is adequate to clear the drug. The reason that milrinone is a concern is because it's active and excreted in largely an unchanged way, exclusively through the kidneys. So if you have kidney injury plus low urine output because of cooling, the risk of refractory hypotension that you're stuck with because they don't clear it, and milrinone has a long half-life anyway, so you're stuck with it. The risk of that and the ischemia reperfusion injury for us outweighs the benefits when we have alternatives available like Butamine. I think if you have an older baby who's more days out, who still has pulmonary hypertension, and you want to try milrinone, they're not cooled anymore, I think that's fair enough. HIE with just brain injury, who have normal kidneys and are not being cooled, I think there's probably a role there. But we've seen this in not only term infants with damaged kidneys and poor clearance, we've also seen it in preterm infants and in post-op cardiac patients. So it's biologically logical that it is a thing. And so we don't typically chance it. In terms of neurological outcomes, that's a really important question that's really difficult to answer because the frequency of these patients is so low in any single clinical practice that it's hard to get a cohort. And if you think about how most people manage pulmonary hypertension in HIE, go back to my 17 definitions of hypotension. Most people give dopamine still. Most people, if the baby has pulmonary hypertension, give dopamine and then milrinone, and then the babies get profoundly tachycardic. They're on the oscillator. You really can't tell what is iatrogenia and what is the baby. And so it's really hard to do science to actually look at that question in a pure way. At some point it needs to be done, but we need to pull up our socks scientifically first.
Great. Regan, thank you so much for a fantastic talk. I know it's 3:15. I think we'll draw things to a close. So I want to thank you again for really stimulating talk and taking through such illustrative cases and working through the physiology for our panelists and attendees. I'd like to thank our panelists again for participation and joining you for this wonderful talk, and the rest of our attendees for joining without their camera on. And finally, I want to thank Laura Thomas, who's our admin extraordinaire, and Dr. Daniel Rios, my co-chair. So thank you again, Regan. Fantastic talk, and looking forward to including you on future broadcasts.
Thanks for the invitation, and thank you, panelists. It's much more fun when you talk to me. So thank you very much. Have a great day.